Breast cancer. According to Philippine Society of Medical Oncology, Philippines has number one incidence of breast cancer in Asia. 3 out of 100 women get cancer before the age of 75, while 1 out of 100 die before reaching 75 years old. It accounts for 15% of all new cancer cases in the country for both sexes, while 8% of all cancer deaths. Breast cancer has no specific cause. However, hormones such as estrogen and progesterone and genetics like mutations of BRCA1 and BRCA2 plays a great role of this disease for this disease. Other risk factors include high-fat diet. Study is still ongoing to explain this one. Oral contraceptives, smoking, its role is still unclear. Increasing age, personal or family history of breast cancer, early menarche, nulliparity and late maternal age at first birth, late menopause, history of benign proliferative breast disease, exposure to radiation, obesity, hormone replacement, and alcohol intake. So there are two main types of breast cancer. The first one is the carcinoma in situ or the non-invasive and the invasive carcinoma. The carcinoma in situ has two subtypes, the ductal carcinoma in situ and the lobular carcinoma in situ, while the invasive carcinoma has the subtypes infiltrating lobular carcinoma, medullary carcinoma, mucinous cancer, tubular ductal cancer, inflammatory carcinoma, and Paget's disease. So let us first tackle the first type, the carcinoma in situ or the non-invasive one. It is detected through mammography and accounted for 20% of all diagnosed breast cancers. It is characterized by proliferation of malignant cells within ducts and lobules without invasion to surrounding tissues. It is considered as stage 0 of breast cancer because it does not metastasize. However, this doesn't mean that it can progress to invasive carcinoma. So as what I've said earlier, there are two subtypes of carcinoma in situ. The first one is the ductal carcinoma in situ or the DCIS, which is the most common of the two types. It is divided again to two subtypes, the comido and the non-comido. It has the capacity to progress to invasive cancer, and treatment is total or simple mastectomy with a cure rate of 98 to 99%. Breast conservation therapy is also considered. It is a limited surgery followed by radiation and appropriate for localized lesions. Tamoxifen is a drug of choice, usually prescribed for 5 years. The next one is the lobular carcinoma in situ or the LCIS, which is characterized by proliferation of cells within the breast lobules. It is usually an incidental finding discovered on pathologic evaluation of breast biopsy and commonly associated with multicentric disease and rarely associated with invasive cancer. Historically, it is treated with bilateral total mastectomy, but was changed when some say that LCIS is a marker of increased risk for development of invasive cancer. Due to this, LCIS needs long-term surveillance, and option is bilateral prophylactic mastectomy. Another one is chemoprevention, and still, same as DCIS, tamoxifen is the chemopreventive agent for 5 years. So let us proceed to invasive carcinoma. The first one is infiltrating ductal carcinoma, which is the most common histologic type of breast cancer and accounts for 75% of all breast cancer. You can feel the hardness when palpated, and usually metastasized to axillary nodes. Prognosis is poorer than all cancer types. The next one is infiltrating lobular carcinoma. This accounts for 5 to 10% of all breast cancers, occur as an ill-defined thickening of the breast as compared with the infiltrating ductal types. This is mostly multicentric, or several areas of thickening may occur in one or both breasts, usually spreads to bone, lungs, liver, brain, or meningeal surfaces and other unusual sites. The next one is medullary carcinoma. This constitutes about 6% of breast cancers, grows in a capsule inside a duct, and can become large. Prognosis is favorable. The third one is the mucinous cancer. It accounts for 3% of all breast cancers, and a mucin or mucus producer, slow-growing type of cancer, and has most favorable prognosis than other types of breast cancers. The next one is tubular ductal cancer. Accounts for 2% of all cancers. Axillary metastases are uncommon, and prognosis is favorable. Next, the inflammatory carcinoma. It is a rare type of breast cancer which only accounts 1 to 2% of all breast cancer types. Symptoms are different from other breast cancers. Tumor is tender and painful. Skin is red and dusky. Breast is abnormally firm and enlarged. Edema and nipple retraction occur, and symptoms rapidly grow more severe and prompt the woman to seek healthcare sooner. It spreads to the other parts of the body rapidly. So the treatment options are chemotherapy, radiation, and surgery to control the spread of the cancer. The last one is the Paget's disease, which accounts 1% of diagnosed breast cancer cases. Symptoms include scaly, burning, itching around the nipple areola complex. Neoplasm is inductal and may be in situ or have invasive cancer cells. Tumor may or may not be present. Mammography often results to negative, so biopsy is the definitive diagnosis of this type of cancer. So let's proceed to the general clinical manifestation of all breast cancers. So breast cancers are usually found in the upper outer quadrant where most breast tissues are located. Lesions are non-tender, fixed rather than mobile, hard with irregular borders, and pain and tenderness during menstruation are associated with benign breast disease. Some women have no signs and symptoms and only seek treatment due to mammographic abnormality. Advanced symptoms include skin dimpling, nipple retraction, or skin ulceration. So let's now proceed to the assessment and the diagnosis. Assessment and diagnosis includes biopsy, tumor staging, analysis of additional prognostic factors, chest x-rays, CT scan, MRI, PET scan, bone scan, and blood work. So staging involves knowing if the cancer is invasive or non-invasive, the size of the tumor, how many lymph nodes are involved, and if it has spread to other parts of the body. The American Joint Committee on Cancer says that there are 3 factors of staging: the tumor, the nodes, and the metastasis. Hormone receptors as well as genetic mutations are also included in staging. So the prognosis has 2 factors. The first one is the tumor and the metastasis. The smaller the tumor, the better the prognosis. Common metastases of breast cancers are bone, lung, liver, pleura, adrenals, skin, and the brain. So now let's proceed to the medical management. It's a surgical management actually. First one is the modified radical mastectomy. performed to treat invasive breast cancer and involves removal of the breast tissues, including the nipple areola complex. A portion of the axillary lymph nodes are also removed in the axillary lymph node dissection. If client wants to reconstruct the breast, client is referred to a plastic surgeon before surgery to explore all available options. Pectoralis major and pectoralis minor are intact, unlike radical mastectomy, in which these muscles are removed. So the next surgical management is the total mastectomy, which is the removal of breast tissue and nipple areola complex but does not include AL and D. It may be performed in clients with non-invasive breast cancer and may also be performed prophylactically in patients who are at high risk for breast cancer. So the next treatment option is the breast conservation treatment. It is to excise the tumor completely and obtain clear margins while achieving an acceptable cosmetic result. For non-invasive, lymph node removal is not needed. However, for invasive, lymph node removal is indicated. Lymph nodes are removed through a separate semicircular incision in the axilla. The next one is a sentinel lymph node biopsy. It is a less invasive and it is an alternative to ALND and is considered as standard of care for the treatment of early stage breast cancer. Sentinel lymph node is the first node in the lymphatic basin that receives drainage from primary tumor in the breast. It is identified via injecting a radioisotope and or blue dye into the breast. It then travels through the lymphatic pathways to the node. Surgeon uses a handheld probe to locate the sentinel lymph node, excises it, and sends it for pathologic analysis. It is done immediately while the patient is still in the OR, and if positive lymph node, the surgeon then immediately proceeds with ALND to prevent patient from having another operation. And if negative lymph node, ALND is not needed to prevent further complications. All specimens are sent again to lab for thorough analysis after the surgery. So here are the priority nursing diagnosis for pre-op patients: deficient knowledge about the planned surgical treatment, anxiety related to diagnosis of cancer, risk for defensive or ineffective coping related to diagnosis of cancer and related treatment options, decisional conflict related to treatment options. For post-op patients, we have acute pain and discomfort related to surgical procedure, peripheral neurovascular dysfunction related to nerve irritation in the affected arm, breast, and chest wall, and disturbed body image related to loss or alteration of the breast. So other treatment options: radiation therapy to decrease the chance of local recurrence in the breast by eradicating residual microscopic cancer cells. External beam radiation is the most common type, begins about 6 weeks after breast conservation and allows surgical site to heal. Deliver high energy protons and is given to entire breast region. If systemic chemo is indicated, radiation therapy begins after its completion. Before radiation therapy starts, patient undergoes planning called simulation, in which the anatomic areas to be treated are mapped out and then identified with small permanent ink markings. So brachytherapy is also a type of radiation which is delivered by an internal device that is placed close to the tumor within the breast. It can lead to an improved quality of life because the treatments are given over 4 to 5 days instead of 5 to 6 weeks. So, the systemic treatment is the chemotherapy. The adjuvant chemotherapy involves the use of anti-cancer agents in addition to the other treatments to delay or prevent the recurrence of breast cancer. It is recommended for patients who have positive lymph nodes or who have invasive tumors greater than 1 centimeter in size, regardless of nodal status. Patients who delay chemo beyond 90 days post surgery have an increased risk of adverse outcomes. So the next one is the hormonal therapy. Adjuvant hormonal therapy with or without chemotherapy is considered in women who have hormone receptor positive tumors. Its use can be determined by the results of an estrogen and progesterone receptor assay. It involves the use of synthetic hormones and other medications that compete with estrogen by binding to the receptor sites or use of aromatase inhibitors, which block estrogen production by the adrenal glands. So, the last one is the targeted therapy. Unlike chemotherapy, this therapy spares the normal cells and has limited adverse reactions, which may include fever, chills, nausea, vomiting, diarrhea, and headache. On a different note, this should not be given to patients which was previously treated with anthracycline because it increases the risk of cardiac toxicity. So, this is the end of our topic. Thank you so much for listening and good day, everyone.